Okay, so today I will take the development of face and tongue. So that will be developing from the primitive stage and also from a cavity that is known as primitive stage, well, primitive embryo, and also from the area known as stomodium. Now, at the end of the third week, what will happen? The embryonic disc, that is the embryonic disc, so that embryonic disc will be folded both headwise and also tailwise. As a result of that, the embryo, that the mid portion of the embryo is projected towards the amniotic cavity, and the yolk sac, because of that folding, will be incorporated inside the embryo and will form the gut. And the fold towards the cranial end, it is known as the head fold, and the fold towards the caudal end is known as the tail fold. Okay, and here the amniotic cavity, this is the amniotic cavity which is formed by the lined by ectoderm, that will come, and the yolk sac which will enter here, that is lined by the endoderm, they will come here and to form a membrane that is known as buccopharyngeal membrane. So this is stomatodium. So stomatodium, after rupturing of the buccopharyngeal membrane, will open into the pharynx. Okay, open into the first part of, or first part of the yolk sac, that is the foregut of yolk sac, and they will communicate with each other. Now here you can see it completely, that this is the amniotic cavity, and this is the neural plate, that is the neural plate that will form later on the what is that, the brain and the spinal cord. Okay, and this is the stomatodium. Here it is covered by the ectoderm, and the yolk sac has entered inside the endoderm. So that two, ectoderm and endoderm, come in contact with each other, that is known as the buccopharyngeal membrane, and the area in front of that, which is continuous with the amniotic sac, that is known as the stomatodium. Okay, similarly, on the tail fold also, one cloacal membrane is formed between the ectoderm and the endoderm, that is the cloacal membrane. By about 23rd day, that is at the end of the fourth week, the buccopharyngeal membrane ruptures. Now here we can see that already you have been taught by by Dr. Amita about the pharyngeal arches. So there are 6 pharyngeal arches. Fifth arch will disappear soon, and from the first arch, two processes are projecting. One is the maxillary process. Another is the mandibular process, and the mesoderm of that will form the arch. The maxillary process, that is the mesoderm of maxillary process, and the mesoderm of mandibular process. Another process will come down in front of the stomodium, that is known as the frontonasal process. So that stomodium, which will form the oral cavity, that is surrounded by 5 prominence. One is the frontonasal process. On both sides there will be the maxillary process. On both sides there will be mandibular process. Is it clear? Now the placodes are formed. What are placodes? The placodes are the ectodermal thickening of the ectodermal thickening by the side of the neural plate. Okay, so these are the placodes. So first placode, that is the otic placode. From this placode, the sensory organs are developed, or the sensory ganglia are developed. About 8 placodes appear by the side of the neural plate. Now these placodes, the first one is the otic placode, then the olfactory placode, then the optic placode, from which the cornea is developed. From the otic placode, the ears will be developed, and from the olfactory placode, the nose will be developed. So here is the olfactory placode, here is the otic placode, here is the lens placode. There are so many other placodes are also present. They will form the spinal ganglia of the cranial nerves, like nodose ganglia for the nodose placode for the vagal ganglia, petrosal placode for the ninth nerve ganglia, geniculate placode for the geniculate ganglia, trigeminal placode for the trigeminal ganglia. That is, these are the placodes. They will appear. And also another placode is there, that is the epibranchial placode, that will form the sensory ganglia of the peripheral nerves. Okay, is it clear? Is it clear? Okay, now, yes, bolo.
It is clear, ma'am.
Okay, okay. Now the neural crest cells also develop during the formation of the neural tube, and that neural crest cells, they will migrate in different direction. They form the melanocytes, they form the adrenal medulla, they form the that is not the pyometer, they form the odontoblast. Similarly, these neural crest cells also migrate to the arches, and these neural crest cells will form the many that will form the that is the muscle mass and the cartilages of the arches. Okay. Now, this neural crest cells, if there is any defect in the migration of these neural crest cells, then there will be facial defect may develop. So, neural crest cell is very important for the formation of the face. Okay. Now, here you can see that this is the frontonasal prominence, and here is the maxillary prominence, and this is the mandibular prominence. And in between these five prominences, there is the buccopharyngeal membrane. Now, at about 23rd to 25th day, it will rupture. Okay, and after some time, the cloacal membrane will also rupture. So this now the stomatodium will open into the amniotic cavity. Now here it has fully ruptured. Now you can see in the frontonasal, by the side of the frontonasal prominence, there are two thickening. These are known as the olfactory placoid or the nasal placoid. And a pit will appear inside this, in the center. At the center there will be a pit that is known as the nasal pit. Later on, by 5th week, when the buccopharyngeal membrane ruptures completely, at that time, the mesoderm surrounding the nasal pit will form two processes. One is the medial nasal process, another is the lateral nasal process. Similarly, on the other side, the medial nasal process and the lateral nasal process. And here, this is the optic placoid. Okay, so you can see two placoids. One is the olfactory placoids. Here is the optic placoid from which the eye, mainly the cornea and the lens, will be developed. Okay, these are all sensory organs, so they are developed from the placoids. And you can see the mandibular prominence already, it has been fused. And this mandibular prominence, mandibular arch, the mesoderm of the mandibular arch will form the lower part of the chin, the lower jaw. It will form the chin and the lower jaw, and the lateral teeth will be developed from these mandibular prominences. Okay. Now here we come, that is a slightly colorful, but I will that same thing I have again telling you that this yellow color is the medial nasal process, the blue color is the lateral nasal process, and that what is that, the maxillary process, this orange color, and this is the mandibular process, and here is the frontonasal prominence, that is the frontonasal prominence, from which the forehead and the root of the nose will be developed. The forehead and the root of the nose will be developed. Now you can see in this picture, the maxillary process is growing towards towards medially. It is growing medially, and it comes below the lateral nasal process, and then it joins the medial nasal process on both sides. And there is a groove you can see between the maxillary process and the lateral nasal process, and that will form the nasolacrimal groove, that is known as the nasolacrimal groove. So here you can see that the mandibular process is compressing the medial nasal process, and two medial nasal process are also compressed with each other, and they will form the bridge of the nose, that is the or crest of the nose. Bridge of the nose is here, crest of the nose and the tip of the nose, crest of the nose and the tip of the nose. Also this medial nasal process, it has actually it has another components is also there. That is, it forms the median part of the upper lip. That is the philtrum. Philtrum. That part is known as the philtrum. Also, it forms the middle part of the upper jaw where the four incisor teeth are attached. So this frontonasal process is known as the premaxilla. It is known as the premaxilla. So it will form the philtrum, it will form the bridge of the nose, it will form the upper jaw, middle of the upper jaw where the four incisor teeth are attached. Okay, yes. Okay, here I have to see, na? Okay, thank you. And you can see that here is the group between the lateral nasal process and the maxillary process that is known as the nasolacrimal group. This nasolacrimal, in the deep to the nasolacrimal group, there will be ectodermal thickening. Later on, that ectodermal thickening is recanalized. It will disappear and there will be a canal. And that canal is known as the nasolacrimal duct or nasolacrimal canal. The upper part of the nasolacrimal duct is dilated and it will form the lacrimal sac. Okay, is it clear? Now come to the development of the intermaxillary segment or the premaxilla. Okay, so there are three components. One, though, the medial nasal component will form the bridge, that is the crest of the nose and the tip of the nose, and then there is a labial component that will form the philtrum, and then there will be the jaw component that will form that here is the philtrum, and that will form the jaw, upper jaw, middle of the upper jaw, and this palatal component. The medial part, there is a palatal component, is also known as the premaxilla. Okay. So here are the three components. The labial component will form the medial part of the upper lip and the philtrum. And there is the jaw, four teeth, incisor teeth are there. And that is the part of the palate which is known as the primary palate or premaxilla. Sorry. Okay. Now the development of the nasal cavity. Now here you can see that the nasal pit is there. The nasal pit is there, which is deepened internally, and that will form the nasal sac or the nasal cavity. Now, now after this is the nasal pit, it will be deepened and it will form the nasal cavity. Now, how this nasal cavity is formed? So here you can see the frontonasal process. This was the stomatodium. This is the frontonasal process. There is the medial nasal process, and it will be entire that will form this is the nasal cavity, nasal pit, and that is the nasal cavity. So nasal cavity is deepened and it is separated from the mouth cavity, that is the stomatodium here, by it can communicate directly, but soon there is a membrane will appear that is known as the oronasal membrane. That is the oronasal membrane. But there is later on this oronasal membrane, it ruptures. It will be canalized and it will disappear. And then the nasal cavity will communicate with the oral cavity. Okay, and this part is known as the primitive guana. Later on, when the palate is formed, the nasal cavity is separated from the oral cavity by the palatine cells. So here, this is the primary maxilla, which is formed by the medial nasal process, and this is the secondary palate, which is developed from the maxilla. And one part will also develop, that is the soft palate, and there is that is also from the maxillary process, but here no bone will be formed. Okay. Now how the development of palate. Now here you can see the labial component of the maxilla, Then you can see the jaw component where the two root will be there, and this is the palatal component or the primitive palate, and this is the maxillary process. Now, from the maxillary process, the palatine two cells they will go medially and also downwards by the side of the tongue. The tongue is developed in the floor of the mouth, and because of the tongue is there, so they cannot grow horizontally. They will go downwards by the side of the tongue. Later on, when the tongue is elevated, then these palatine cells they come horizontally and they will meet with each other. Now here you can see this is the palatine cell, here is the tongue, the development of the tongue, and this is the frontonasal process which is forming the nasal septum here. And here they are growing downwards and medially. But when the tongue is depressed, then the two palatine cells they will be they will grow towards each other and they join with each other. Now this nasal septum which is formed from the frontonasal process that will also descend, and here you can see the lower part of the frontonasal process or the lower part of the nasal septum. Here the palatal cell they will meet with each other as well as with the nasal septum. Okay, it is the ventral view, it is coronal section. Now, here they are coming horizontally and they will meet with each other. And this is the nasal septum. They will also meet with the nasal septum. It will go downwards and meet at the center of the palatine, fused palatine cells. Okay. Now, here also you can see that the two palatine cells they are fused with each other and the tongue is below. The tongue is below that palatine cell. And this yellow portion, what is that? That is known as primary palate. This is primary palate. It is formed by the medial nasal process. Okay. Is it clear? Okay.
Ma'am.
Yes. Yes. Who are you? Now, the paranasal sinus. What are the paranasal sinus? These are the mucous lining cavity. They are the mucous lining cavity inside the cranial bones, and they are projected. They are projected from the nasal cavity actually to the surrounding cranial bone, and they are lined by the respiratory epithelium because the olfactory plateau from which the nasal cavity nose is developed, that olfactory nasal pit. So there will be an epithelium. That epithelium are of two types. One is the olfactory epithelium, another is the respiratory epithelium. But this paranasal sinus, they will be covered by the respiratory epithelium. These are outgrowth of the nasal cavity and they entered into the surrounding cranial bone. So when they entered into the frontal bone, that is known as the frontal air sinus. When they enter into the maxillary bone, that is known as the maxillary air sinus. When they enter into the sphenoid bone, that will form the sphenoidal air sinus. They also enter into the ethmoid bone, that is present in our nose, in the upper part of the nose. That bone is the ethmoid bone, and they enter in the ethmoid bone, and they will form the ethmoidal air sinus. Is it clear? Now, how the ear is developed. Now, this here you can see this is the stomatodium. This is the first cleft. This is the second cleft. In between, this is the first arch. This is the second arch. In between them, there is the first cleft. Surrounding the first pharyngeal cleft, there are 6 swellings will appear. So these swellings are known as auricular hillocks. Auricular hillocks. Later on, they will enlarge and they will change their shape, and ultimately the ear is formed. So ear is formed from the 6 hillocks surrounding the the first cleft. Surrounding the first cleft, there are 6 hillocks. They will unite with each other. They will change their shape and form the external ear or pinna. Not the whole of the external ear, but the pinna. The eustachian tube, that is the ear canal. How it is formed? From what side it will be formed? In the pouch, yes, good. So in the first pharyngeal pouch, it will come towards the first pharyngeal cleft, and later on there will be disappearance of the membrane between the pouch and the cleft, and the external auditory meatus will be formed. Okay, so that is the development of auricle. So it is very complicated development, isn't it? The six hillocks, they are enlarging and they are fusing with each other to form the ear. So pinna abnormality are more common. Now here you can see some of the pinna abnormality. There may be a opening in front of the ear. Usually it is above the external auditory meatus or the tragus, but sometimes it may be below. And it is a benign condition. Only the cosmetic value may be there, and sometimes it may project. There is a cavity, and that cavity is known as the auricular sinus. Sometimes there will be infection may occur. Okay, so that is the periauricular, preauricular sinus or preauricular pit. Another is the preauricular appendage. You can see some of the swellings are there. These are muscular swelling, fleshy swelling. Okay, and these fleshy swelling are due to the persistence of the auricular hillock in front of the ear. So that is known as the preauricular appendage. And that ear, it is developed near the neck, and then it is elevated. Then it is elevated at the level of the eye. Our ear is at the level of the eye. Okay. Now here it is low set because there is failure of ascent, and the ear is formed that is also smaller. So it is known as microtia, and that is the low set ear. It is also common. Microtia and low set ear is there. So these are the some of the auricular abnormalities. So again, I am completing. I will go to the summary. From the frontonasal process, what structures are developed? Forehead, bridge of the nose, and the nasal septum. Okay. Then from the lateral nasal process, the side of the nose and the ala of the nose, and the side of the nose. From the medial nasal process, the philtrum, the primary palate, the median part of the upper jaw, and crest and tip of the nose. I have written haphazardly. First, there will be the crest and tip of the nose, then there will be philtrum, then there will be median part of the upper jaw, then there will be primary palate. Okay. Then from the maxillary process, what is developed? That is the lateral part of the upper lip here, and also the cheek, that is cheek. The mandibular process, that will form the lower jaw, then the lower lip, and also the maxillary process and the mandibular process, they meet with each other and they form the cheek. And if they don't meet with each other, the oral fissure will be from ear to ear, isn't it? From ear to ear. But they will fuse with each other and that will form the cheek. In dogs, you find any cheek in dogs? Hello. Yes, Bhagya. Huh? 22. So, have you seen any cheek in the dog? No or yes?
Yes, ma'am.
Yes, there is
ল্যাবরেটরি
a
থাকে
cheek.
ম্যাম,
Okay,
ল্যাবরেটরি
so
দেখেছি।
that is towards the ear, isn't it? That is towards more laterally, isn't it? You can just that is cuddle them by there, but here in a baby you can cuddle the baby in their cheek, because the maxillary process and the mandibular process, they fuse with each other and they make the oral fissure small. Then the group between the maxillary and the lateral nasal process will form the nasolacrimal duct. Now the facial abnormalities. Now facial abnormalities are due to three factors. I have written 4 factors. One is the migration of the proper migration of the neural crest cells. Also the apoptosis. When the palatal cells are joining, there will be apoptosis or the programmed cell death. If there is no apoptosis or the programmed cell death, there will be abnormality. Then some drugs, like the anti-cancer drug, anticonvulsant drug, also for some acne, they use some chemicals. These drugs may cause cleft lip and the cleft palate, or there may be genetic defect. Okay, some growth factors are also responsible for the formation of these organs, and if there is genetic defect, then there will be facial abnormality. Now, unilateral cleft lip is very common. Here, this maxillary process fails to unite with the medial nasal process on one side, so it is unilateral. If that failure on both sides, then it will be bilateral. This is the medial nasal process. This is the part, median part of the lip is there. And sometimes the frontonasal process is deficient, so there the bridge of the nose will be not, root of the nose will be not there, but the crest is formed, but that is also not very clear, and the tip of the nose is formed. Okay, because this is formed from the medial nasal and the lateral nasal process. The upper part of the nose, like that is the root of the nose, that will be formed from the frontonasal process. Also, if the lateral nasal process and the maxillary process, they do not meet with each other, then there will be the cleft in the nasolacrimal, in the region of the nasolacrimal group, there will be a cleft that is known as the oblique facial cleft. Usually the cleft lip and the cleft palate, they are associated with each other. This is the macrostomata, though it is not so much, but if the maxillary process and the mandibular process, they fail to merge with each other, instead the cheek will be smaller and the oral fissure will be very long. And this is the median nasal cleft, because here the two medial nasal process, they do not meet, or there may be neural crest cells, migration of the neural crest cells may be abnormal. So it is very rare. It is a median cleft lip. It is a very median cleft lip. Okay. Now come to the palatal abnormalities. Usually, along with the cleft palate, there is cleft lip. There will be cleft palate. It may occur only in the soft palate region. So that is the posterior cleft, and it may be complete. But the nasal septum, it meets with one of the palatal cell. So this is the unilateral cleft. Unilateral cleft. Okay. But it is a complete cleft. And sometimes there will be bilateral cleft lip and plate. And that is the medial nasal process. In the palate, there will be a median cleft, but actually it is the bilateral cleft lip, and here the medial nasal septum cannot fuse with the palatal cells. Okay. Now come to the development of tongue. So development of tongue, the tongue is also developed from the facial arch, facial bullet. That is the branchial arches. They are also, it is also developed from the branchial arches. So suppose this is the first arch, that is the mandibular arch. This is the second arch, that is the hyoid arch. The third arch, the nerve supplied by the glossopharyngeal nerve. And this is the fourth arch. The sixth arch, here they have shown the first arch, second arch, third arch, fourth arch. This is the sixth arch. And in between them, there is no fifth arch. The fifth arch only form the what structures? What ultimately they will form? The fifth arch, what ultimately they will form? That is the ultimobranchial body. Can you hear me? Hello?
Yes,
Yes, ma'am.
ma'am, we can hear you.
Okay, but you are not giving any answer. I am asking you a question. You are laughing. Okay, so only on myself you will not discuss with me. Okay, now for the tongue there will be some swellings will appear. In the first arch there will be three swelling. That is the medium swelling, that is known as tuberculum impar, and two lateral swelling. These are known as the lingual swelling. Lingual means it will form tongue. Okay, so these two lingual swelling, they will enlarge and they will fuse with each other. and they will also fuse with the tuberculum impact, and they form a large mass, and that large mass is attached to the floor of the mouth. And that large mass later on it will form the anterior two-third of tongue, mainly by the lingual swelling. Now this maxillary arch, which is the nerve of the maxillary arch, which is the nerve of the maxillary arch,
Mandibular nerve, maxillary nerve.
oh, so they are telling from behind and you are hearing that and giving. Nah? So that is the tongue, the anterior two-third of the tongue, it is supplied by the mandibular nerve. That is the branch of the mandibular nerve, that is the lingual nerve. Branch of the mandibular nerve is the one of the branch is lingual nerve. So that will supply here. Then there will be another prominence will appear. That will present in the second arch, third arch, and the fourth arch, but mainly in the third arch. That third arch will again overlap the second arch. So second arch will not come for the formation of the tongue. Only the third arch and the fourth arch will come. And that swelling covering the second, third, and fourth arch, that is known as the hypobranchial eminence. This hypobranchial eminence is again divided into a upper part and the lower part, or cranial part and the caudal part. Now this cranial part is known as the copula. The cranial part, this is the hypobranchial eminence. Okay, and the third arch is enlarged and it overlaps the second arch. So you cannot see the second arch. This is 2 is the tuberculum impact. So that is the first arch, and here is the third arch. And this cranial part is known as the copula. The copula is present in the fourth arch also. So from this copula, the posterior one-third of the tongue and the posterior most part of the tongue is developed. So it will be supplied by the nerve of the third arch is glossopharyngeal nerve. So third arch that will form the posterior one-third part of the tongue, that will be supplied by the glossopharyngeal. But the most posterior part of the tongue, it is also developed from the copula, but the nerve of the fourth arch is the laryngeal nerve, superior laryngeal nerve. So that part will be supplied by the branch of vagus nerve. Now there is another swelling hypobranchial eminence, that is the caudal part of the hypobranchial eminence, that is known as the epiglottal swelling or epiglottic swelling. From that epiglottic swelling, the cartilage of the larynx will be developed because it is the sixth arch. Right? So epiglottic swelling, the cartilage of the larynx, that is the epiglottis, will be developed. And from the sixth arch, the other cartilage like the arytenoid cartilage, other whatever the cartilage are, the cricoid cartilage, they are developed from the sixth arch. Okay. And in that between the arytenoid and cricoid, there will be an opening, that is the laryngeal opening. Okay, this is fourth arch, this is sixth arch, this is third arch. Okay. Now the tongue is developed already. Now here that part is developed from the first arch, that will form the body, side, tongue, anterior two-third of the tongue. This is the third arch. From the third arch, the posterior part of the tongue, and this is the fourth arch. From the fourth arch, the most posterior part of the tongue, and then it forms the epiglottis. At the junction of the anterior two-third and the posterior one-third, there will be a sulcus, that is known as terminal sulcus. The taste buds will also appear by about 10th week of intrauterine life. Taste bud starts to appear here. Okay, but in the posterior part, there will be the papilla and the taste buds, they will be formed here. Taste buds are also found in the posterior part, but there will be no papilla. Only there will be the lymph nodules that will form the lingual tonsil. Sorry. Now, I have told you the tongue, the anterior two-third of the tongue, initially it was fixed to the floor of the mouth. Later on, there will be a downgrowth of the epidermal thickening. So that is the epidermal thickening. Now that epidermal thickening later disappear and a sulcus is formed. A sulcus is formed between the tongue and the floor of the mouth. and that is known as the lingual sulcus. So we can move our anterior two-thirds of the tongue. So the anterior two-thirds of the tongue is the mobile part of the tongue. The posterior one-third part of the tongue is the fixed part of the tongue. Now here, the muscles of the tongue, from where they are developed, they are coming from the somites. So what are the somites? They are the part of the paraxial mesoderm. Paraxial mesoderm, have you heard the term paraxial mesoderm?
Yes, ma'am.
Yes, ma'am.
Ma'am.
Okay. So this paraxial mesoderm give many things, and from that there the somites are developed. There are so many 21 or 23 somites are 33, no? 33 somites. So many somites are developed, 33 I think, and 33 to 39. Now this is the preoptic somite, isn't it?
No, beta occipital.
No, this is occipital. This is the preoccipital myotum. Now from this preoccipital myotum, the extraocular muscles are developed. Okay, and from the occipital myotoms, the tongue muscles are developed. So they will migrate. The myotoms, that muscle cells, they will migrate to the first arch, and they will form the tongue muscles. They will form the tongue muscles. Okay, they will form the tongue muscles. From the tongue muscles are developed from the occipital myotome. Now the nerve supply. Now the nerve supply of the tongue, I have already said that the first two-third, anterior two-third, is supplied by the lingual branch, because it is the first one two-third is developed from the mandibular arch. Suppose this is the mandibular arch, so that one will be developed from the first arch, anterior two-third. So it will be supplied by the lingual branch. This is the second branch, second arch. So here that is the facial nerve. Facial nerve. Now that facial nerve gives a branch which will go above the first cleft, above the first cleft. Okay, so it is known as the pretraumatic branch, because trima means cleft. The trima, this is first pouch. So on other side that there is the cleft. So it is the above the cleft, it will go and enter into the first arch. So it is the pretraumatic branch of the first pharyngeal arch, that is the chorda tympani, and that chorda tympani will supply, will carry the taste sensations from the anterior two-third of the tongue. Is it clear? Is it clear? Are?
Yes, ma'am.
Bolo to coach. Then the second arch, and this is the third arch. Now second arch does not take part in formation of the second pharyngeal formation of the tongue, because it is overlapped by the third pharyngeal arch. Okay, so we will not come to that. No, we will come to the third arch. So third arch, which nerve is there? That is the glossopharyngeal nerve. Glossopharyngeal nerve. And it also gives a branch to the second arch, that is known as tympanic branch. We have no connection, we have means we have no work with this tympanic branch of the glossopharyngeal nerve. But the glossopharyngeal nerve itself enters into the third arch, and it will carry both the general sensation as well as the taste sensation. And the muscles of the tongue, they are developed from which myotome? Occipital myotome. So occipital myotome, they are developed from the occipital myotome. So they will be supplied by hypoglossal nerve. Okay, so that is the nerve supply. So the anterior two-third mucous membrane is formed by the first arch, and nerve supply will be the lingual nerve, chorda tympani nerve. Okay, posterior one-third mucous membrane will be formed by the third arch, that will be supplied by the glossopharyngeal nerve, and the posterior most part will be formed by the fourth arch, and that will be supplied by the superior laryngeal nerve, which is a branch of the internal laryngeal nerve. And the muscles of the tongue are developed from the occipital myotome, that will be supplied by the hypoglossal nerve. Now these are the some of the developmental anomaly of the tongue. Now can you see any tongue here? No. So that is aglossia. It's very rare, aglossia. So when there will be aglossia, there will be difficulty in speech, difficulty in swallowing, all these things will be there. And here the tongue is very small and it is, you cannot, the tongue is very small, so it is known as microglossia. Usually it is associated with another syndrome that is known as the orofacial dactylar syndrome. Orofacial dactylar syndrome. So there will be there will be usually there is how many, 1, 2, 3, 4, 5, but the fingers are very small or toes will be very small. There are so many pictures about the dactylia. I have pasted one here. Okay, here the tongue is very large. That is known as the macroglossia. In that also, there will be difficulty in speech, difficulty in swallowing, difficulty to move the mouth, move the tongue inside the mouth. Okay, and that is the ankyloglossia. You can see the anterior part of the tongue. It is, though it is clear from here, not very much clear, and it is attached on one side in the median part, that is known as the frenulum linguae. So by this frenulum linguae, it is attached to the floor of the mouth, but on the laterally, it is usually free. But if the lingual sulcus is not formed, then it is fixed to the mandibular, that is to the floor of the mouth, and we cannot protrude the tongue, and that is known as ankyloglossia, attached tongue, ankyloglossia. Okay. Now another development is there, that is the bifid tongue. If the two lingual swelling, they do not fuse with each other perfectly, so at the tip there may be one cleft is there, and in very severe case there may be a sulcus is present in the on the dorsal aspect of the tongue. So that is due to failure of fusion of the lingual swelling. Now they have found recently in 2015 or 17, they have found one tongue which is associated with polydactyly. Okay, so that is pentafid tongue. Close with, एक बज गया क्या? Can you hear me? Hello, 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 Arkojit.
Yes, ma'am.
Okay. So here you can see five prominences, five bifurcation. Okay, so this is known as the pentafid tongue, and along with it is a part of a syndrome. With there is usually usually one finger is extra, so that is known as the polydactyly. Have you seen any polydactyly in any actor? Yes.
Hrithik Roshan.
Hrithik Roshan.
Hrithik
Hrithik
Roshan.
Roshan.
But Hrithik Roshan has pentafid tongue or not, I don't know. Okay. Okay, it is because of the neural crest cells, they are migrating, and if they are not migrating properly, if they are migrating in different direction, then there will be different regions, pentafid tongue you can get. Okay. Now, that type of tongue you have seen many person. It is a benign condition. This is the fissure tongue. Fissure tongue. So there will be fissure anterior posteriorly. These are usually benign. This is the geographic tongue. There will be red patches on the tongue, and that is surrounded by the white line. Okay, it is a geographic tongue. These deep patches, they don't have any filiform papilla, which gives the roughness of the what is the tongue. So there is no filiform papilla. So there is this area are red, and they are surrounded by the rough tongue, and that is the whitish margin. So that is the geographical tongue. Sometimes we may get, that is a rare condition, in the midline that there is loss of filiform papilla, and there will be a red patch in the midline, and that is known as median rhomboid glossitis. Hairy tongue. Hairy tongue. That means hair inside the tongue, hair over the tongue. Okay, it is hair or anything else. It is not hair. There are no hair follicles in the tongue, but there are keratins are present. Keratins are present over the filiform papillae. So over that filiform papillae, these queratives are darkened, more darkened, and they will form, and the filiform papillae are slightly slanting. So they look like hairs, but actually they are not hairs. They are keratin, more keratinization of over the filiform papillae. So that is the hairy tongue. Okay?
Ma'am,
Yes.
ma'am, can you repeat the third picture, the median rhomboid glossitis? Why is it caused?
Glossitis, because there is no, that is a smooth part of the tongue, and glossitis means inflammation of the tongue. That is the smooth part of the tongue, and inflammation may occur here. So that is known as the median rhomboid glossitis. Glossitis means itis means inflammation, inflammation of the tongue. So when there will be inflammation, there will be pain. So sometimes there may be pain if there is glossitis. Okay.
Yes, ma'am. Thank you, ma'am.
Okay, so what is intermaxillary segment? You have to write. I have shown you there are three components. Three components. What are they? Labial component, palatal component, and the jaw component. So what structures are developed from the labial component? That is the, what is that? Philtrum. From the jaw component, the middle part of the jaw. Rest of the jaw is formed by the maxillary arch, and along with that middle part of the jaw, they will form the four teeth, four incisor teeth will be there, and also the primary palate will be developed from there. Okay. What are the developmental swellings of the tongue? You know, the lingual swelling and tubercular impact, mainly the lingual swelling. So these are the assignment. Okay. And correlate the development of tongue with their nerve supply. Only three questions. Okay. So thank you.